Everybody, welcome to the TIMGA Podcast. My name is Mohammed Khalif, and today I'm here with Amy Grunder, Director of State Government Affairs, and Dr. Robert Marlin. He's the Special Advisor for Healthcare Workforce, and they are both representing the Massachusetts Immigrant and Refugee Advocacy Coalition, also known as MIRA. MIRA's mission is to convene, serve, and organize together with their members, community leaders, and allies for the advancement of all immigrants across the Commonwealth and beyond. MIRA's coalition places immigrant and refugees' voices at the forefront to advocate for the well-being of their communities. Thank you so much for coming on to this podcast, Rob and Amy. I'm really excited to talk about Massachusetts and, some of the work that you guys are doing. You guys are kind of like flying under the radar. Like not a lot of people are talking about IMG policy, in Massachusetts, but you guys, got a lot of work done. So just really excited to have you here.
Thanks for having us.
We're excited to be here.
So tell me, how did you guys get into MIRA and the background of like advocacy and helping shape this policy? I just want to learn a little bit about you guys. So maybe we'll start with Amy. How did you get into this space?
Well, I've been at MIRA since 2015, but when I arrived at MIRA, there had already been substantial work done on this issue. There was a governor's task force on immigrant healthcare professionals that issued a report in 2014 and submitted it to our then governor, Deval Patrick. And that was more or less, that was a report sort of highlighting the barriers and other issues facing immigrant healthcare professionals generally, not only physicians, but in all the healthcare professions, and also recommending changes that could be made at the executive level.
Yeah.
Right. And that was filed sort of near the end of the Patrick administration, and the subsequent administration didn't really take those recommendations up.
Yeah.
But that was the beginning. That was the beginning. And then in 2019, we filed legislation to create a commission on foreign trained medical professionals. And that bill was filed by Senator Jason Lewis in Massachusetts and Representative Jack Lewis. Once that was filed, we got it. The senator actually got it adopted into the budget. Yeah. So in 2019, it was passed as legislation, and this was a stakeholder commission. So it was including kind of all the stakeholders you would want, whose support you would want. It was tasked with creating actual changes to licensure. Yeah. But again, it was across all the professions, but it ended up focusing more on physicians. It was chaired by the director of healthcare licensure in the Department of Public Health. It had key legislators. It had, who else did it have? It had the Mass Medical Society. It had members of the Mass League. It was the Mass League of Community Health Centers, which is, how would you describe that, Rob, in more generic terms for other folks?
It's like a primary care association for most of the states. But I think, Mohammed, it started a long time before that.
And we'll definitely dig deep, into detail. But I just want to I want our viewers to kind of know you guys a little bit. Like Amy, did you come into this role as the Director of State Government Affairs? And what was your background before that? How did you get into the space?
So I'm an attorney, and I actually practiced appellate asylum law before taking this job. So it was new for me to work in legislative advocacy. And this was actually, I would have to say that this is the first big win that I experienced. Nice. Was, the shepherding of this process through a commission and then finally into legislation and across the finish line. So it was super exciting for me.
Yeah. How about you, Rob? I know you're a physician. What was your background, in what specialty, and, how did you get yourself into, the MIRA coalition?
So I'm a primary care internal medicine physician. And for my whole professional life, I've worked at MIRA members. All the healthcare institutions I've been at have been members of MIRA. So for me, practicing medicine and thinking about immigrant and refugee issues are pretty much the same thing. And before I practiced in medicine, I trained as a medical anthropologist, and my focus was on the healthcare issues that refugees experience around the world. And I was glad to come back to the U.S. after a while and find that there were refugees and immigrants who needed advocacy locally as well.
Yeah, yeah, yeah. Nice, nice. And Amy, you touched on it a little bit on how the stakeholder convening started, and the different members that were involved to get that first stakeholder meeting underway. And Rob, you can chime in as well. What was some of the barriers to get to that point? Like, when you guys proposed the idea of, hey, let's get together, let's get everybody involved to talk about IMGs and what they could do here in the state of Massachusetts. And so, what was the barriers to getting that up the ground?
The commission actually wasn't hard to get into off the ground, actually, because we had a really terrific sponsor in the state legislature who really cared about this issue. A constituent had gone to him who was a physician from Iran and just came to him in absolute frustration. It was a new issue for him. And I think that in terms of legislation, we were really helped by the fact that the state legislators were really cognizant of the physician shortage. We were just coming out of the pandemic. I would say the pandemic was the biggest barrier because we didn't, even though the commission was formed, it didn't get underway until 2021. It was a major delay, again, because of the pandemic.
Yeah.
But I actually think that, because of the way we created the commission, because we got all the key stakeholders on board early when we were discussing the framework here, and Rob, Dr. Marlin here is the one responsible for that framework because we were both members of that commission. But having all those folks on board made the path, that plus the urgency that the legislature felt, actually gave surprising momentum to the bill right from the get-go. I don't know if, Rob, you want to add something here. I mean, it was timing. It was
I
perfect
agree,
timing.
but we have to keep in mind it wasn't the first commission or special
That's
committee.
Right. That's right.
This has a history in Massachusetts going back to the 1950s. So even though it got off the ground pretty easily, if you look at what's happened before, they never really gained the same kind of traction. So we were glad that it launched, but we didn't have any guarantee that our recommendations coming out of the commission would be taken up by the legislature.
Interesting. I didn't know there was a history behind it. So these pathways been proposed in the past. You said going back to the 50s.
So there's a wonderful paper which I hope will be published soon by Tricia Pariel, who is a medical student at Boston University, and she looked at the history of internationally trained physicians trying to get licensed in Massachusetts and found that it really does go back to the 50s with the Board of Medicine. And this is the time when ECFMG, the Educational Commission for Foreign Medical Graduates, was just being formed, in part because of what came out of Massachusetts. A lot of people just threw up their hands at the time and said, we can't figure this out. And we're living with that legacy still. And we hope that the legislation we've passed, the PPA, is going to finally resolve it after about 75 years.
Yeah, nice. That is an amazing, and I'm looking forward to reading that paper, and it's looks pretty interesting. I did not know that, so really nice stuff. So, Amy, would you say, speaking to MIRA specifically, because you guys brought the advocacy forward, right? You guys were the first ones to say, "Hey, let's do this." What prompted MIRA from taking this initiative on? Because I know you guys, MIRA could be maybe solving dentists or another type of profession, right? Or maybe some other things. What made it easy or helped you guys to say, hey, we need more doctors here?
I think the focus on doctors didn't actually come through until we were actually working together with the commission. We were interested in broadening access for all different professionals, and I think partly the emphasis on physicians came again from the sponsor of the commission legislation, who was a really big supporter. But at the beginning, when we first started, we were fairly open, but we were interested in getting licensure changes through, because that was a really big barrier, different from, say, other types of barriers like the opacity of the process, various things that states could do to improve things. We wanted to do something really significant. We are also thinking about, for example, dentistry, for example, because in Massachusetts, dentists, internationally trained dentists have a limited license and under supervision, and they remain in limited licensure forever. There's no pathway to permanent licensure. So we're really interested in thinking out of the box. And Rob, I'm not sure if you have anything to add there. We were fairly open in the beginning, and then everyone just kind of focused on physicians on the commission, right?
I think because there is a very clear lack of primary care, specifically in the state. There's definitely a lack of dental access. There's a lack of other access as well, but it's very much in the forefront of the public discussion. And because I think we had the resources, meaning the stakeholders and the team, to be able to put forward a proposal that would have traction for physicians. I don't think we had as much information on dentistry. In a way, we thought, let's go forward with physicians first. And if we can do this, we think we can tackle anything else.
Yeah. And Rob, like, when you were talking to different stakeholders, were there anybody who said, like, what are you doing? Like, this doesn't make sense, or like residency, is the only way, we have to follow the traditional pathways. Let's create more residency spots. Let's not like create these alternative pathways. And like, what was your response to that?
Well, we definitely do hear people say, and I have to say it's decreasing over the years, they should just do residency. But I've never heard anyone say, let's increase residency spots, because they really don't have a way to do it here. So most people will say, they definitely don't think there's any appetite for CMS to increase residency slots. And most of the academic centers around here are not trying to do it. So that, for some reason, I know it's worked in other states like Washington, but here there was no consideration of it, really, because people thought that was the hardest thing on earth to do. So that's why, not that they thought what we were doing was easy, but they thought it's easier than creating more residency slots. And to be honest, it's just one of many ways to try to increase the number of physicians and access to care. We would welcome the idea of creating more residency slots at the same time, but the number that we would create would not make a sufficient difference in access the way that this licensure model could.
Yeah, that's great. I mean, like here in Washington State, like we started as that model. Hey, like let's create a clinical experience program so people can get experience for a couple of years, then go to residency. But eventually, what we found out is like people got the experience and just like went to someplace else, or like maybe like didn't, the community kind of lost out on physicians. Like somebody had like a panel of like 1,000 patients, and then like the next day they got into match and they're gone. So like yeah, and then right now we're kind of like figuring out, hey, like how do we graduate like these folks who've done like so many years of experiences to a full license, what we need to do. So these are the things that we're trying to do here. And honestly, like it's hard to get the federal government to fund that much residency spots, right? Amy, do you think that's the like people should, that's why states are taking this on, is because like the federal government is not paying for these spots?
Yeah, and from what I understand is that the limited residency spots that there are favor people who are recently graduated. So you have this complete irony, graduated from medical school, right? So you have this irony where people are in Massachusetts with lots of experience, and the more experience they have, the less likely they are to get a residency spot. So there was that issue. But to respond to your other point earlier, I think there was also an interest in specifically having internationally trained physicians build out our healthcare delivery system. And the reason for that is we have one of the most diverse immigrant populations in the country. Yeah. And many of the places that are least served, once you get outside of Greater Boston, there's not a lot of access to physicians, right? Yeah. There's a lot of them in Suffolk County, right around Greater Boston. But the populations that need to be served are very diverse. And we know that there's evidence that people who are served by people who are not part of the dominant majority, if you will, there's better healthcare outcomes if they're treated by physicians who are also not part of the dominant majority. Right?
Yeah. And that's a really great point. And like Rob, I'd love you to touch base like more, like maybe talk about that a little bit more. Because you serve patients with diverse backgrounds, and I'm sure there's a point that you said, "Hey, I wish like these doctors like could take care of my patients, because like they could do a better job.
Well, some of those doctors are my patients. In fact, that's
Yeah.
how I started thinking about this issue first 20 years ago, because I encountered patients from all over the world who said, "Oh, I'm a physician too, but I can't get licensed here," or colleagues who were
Mhm.
working in the hospital, janitorial staff. We all know what kind of jobs these colleagues take. Yeah, I definitely agree with what Amy said. And it's not that people have to be matched exactly with language or foreign background or national background. That's not it. It's just not being from the dominant group really helps. I mean, for me, for most of my practice, I've cared for a lot of patients who speak Portuguese, which I do too. So we sort
Mhm.
of have that in common. And I can see what difference it makes when someone can communicate with you in the same language or a second language you share. It makes a big difference. And I've heard from patients too. I really wish I could have a doctor who spoke the same language as me, who looked like me, and it's or who shared the experience of being an immigrant. I think that's really the crux of it. It doesn't have to be
Mhm.
that specific, but knowing the difficulties that everyone experiences when they come to the US and when they're here makes a big difference.
Yeah. That's very true. Like, there was a physician I interviewed a couple of weeks ago, and he told me he had like an Afghan patient that had like high lead levels all the time, and the janitor told him probably they're using these eyelashes that contain like high lead stuff. So, and that was the problem, right?
Right,
So
right.
yeah,
Shocking.
and that like the janitor was a
Wow.
physician. So really, some really great stuff that you mentioned right there. So next thing I want to know is like, how long did it take from, okay, stakeholder convening, and we agree on these rules, like we agree like how this policy should look like, because like we know like now 20 plus states have policies, they all look different, right? Like
Yep.
and how long did it take for you guys to agree on, hey, this is how the Massachusetts policy should look like?
Well, we met for less than a year, starting in September of 2021. The final report was issued in 2022. We managed to build the support of the entire commission for the framework that we ultimately came up with. And then once that report came out, we were able to point to it, obviously, when we filed the legislation. The next legislative session began in January 2023. And the funny thing is, when we filed that legislation, we hadn't even heard that other states were trying to remove the residency requirement
Mm,
for licensure. We weren't aware of what was happening nationally,
wow.
and we filed it. So we were the first. I believe we were the first in the country to actually file the legislation. But by the time we passed it, 9 other states had filed and enacted the
Yeah.
legislation. And I always say, to be fair, some state legislatures have a 1-year legislative session,
Yeah.
but still, it was kind of remarkable in that 2-year period how it just came out of how many states. I think
Yeah.
there were 9 by the time we passed
Mhm.
ours at the end of the session, which was in November 2024. But now there's something like 22 states
But
Yeah.
we
now.
consider ourselves the tortoise. We still think we're going to win the race
That's right.
by having
Nice.
people actually in practice
That's
first.
amazing. That's amazing. That's amazing. That's amazing. So also like one thing, like I analyze a lot of different you know policies and different basically rules that they like people put out for IMGs, and you'll see some that require like, hey, they have to be from certain countries. You'll see some that require, they have to have like a fixed, like a residency. And you'll see some that kind of like understand, like I think your policy is good where, and you can correct me if I'm wrong. Like a GP, let's say a physician who's from like somewhere in, let's say, Asia, who's like done medical school and maybe worked as a GP, because there's a lot of pathways around the world where somebody just finishes medical school, they work for the government for a year, and then they do like a national service, and then they go out, they work as a GP, right? So Massachusetts is recognizing those type of IMGs, right? Like who have a license from their country and maybe worked as a GP rather than doing like a formal international residency program.
Well, it could be either, and that's why um, we use the term internationally trained physician, and by that we mean someone who has completed their training and been licensed or authorized to practice for some period of time. Like you say, a GP
For
in
1
some
year or
countries
more.
for at least 1
At
year or
least a
more,
year. Yep.
for at least
Yeah.
a year. So it's a subset of IMGs, but it's more specific. So it's not
Yeah.
someone right out of training, right out of school. They have to have practiced for some period of time, at least a year.
Yeah, but that's amazing, and that's what I like, because that kind of accounts for all the most of the world that goes through that, right? Like like most of the world, you won't see like a lot of formal residency programs, like especially in the primary care area, right? And so that's why I think you guys really put forward. Was there a lot of like disagreements when it came to, hey, like what the qualifications should be, like step 3 or not, like this type of IMG or not? Like were there any kind of disagreements?
I don't think there was a lot of disagreement, because in the end, in terms of what we changed in the state law and the state guidelines for licensure, there wasn't a lot that we took away. The main one was, we said you don't have to have completed graduate medical education in the US, because that was in our state law, that to get a license you had to do that. So that was really the biggest barrier that we needed to remove. And then what we needed to add was the framework for a licensure program that would help support people as they learned how to operate in the Massachusetts specific and US practice environment. So we didn't add a lot of specificity. We didn't say you have to have done this kind of program or that kind of program. We want people to get licensed, and then the institutions that are going to hire them, others can choose. Oh, we may not want to hire the person from that school or that training program, but at least get them to be in the position to have the same ability to get licensed as other people. That was really the main thrust.
Yeah. Amy, you want to add anything?
Yeah, I would just add, so what it substitutes is a non-clinical assessment evaluation program, right? And it's very specific. The law actually says that the Board of Registration of Medicine can add other requirements other than what's mentioned there, except for clinical training. Can't require that. Another distinction is there's no formal supervision. It's and the physician will get paid. They're allowed to practice full scope medicine, and they get paid for their work, right?
Yeah.
And Rob, you can fill in here. But another thing I would say that's really important to an earlier point you made, which is that another unique thing about this legislation or this law is that there's a service requirement. Right? There's a service requirement. So the law requires that somebody participate in this initial program, to familiarize themselves with the Massachusetts practice environment for a year under limited licensure, and that license can be renewed once. And then that's followed by a 2-year restricted license to practice anywhere in the state, except it has to be in a shortage area or population. They have to be serving a shortage area or population, and it has to be in a shortage specialty. So initially, they're restricted to practice in that program at a federally qualified healthcare center or a community health center or a hospital approved by the board. So what this does is it places a physician in a place where we most need access to primary care physicians and psychiatry, right?
Yeah.
And the other feature, though, is once someone has spent enough time in one of these areas serving a particular population, they're more likely to stay there.
Yeah.
They're not likely to go somewhere else in the state. And so that's another feature that helps support, that helps strengthen access to healthcare in Massachusetts. I don't know if you want to add something, Rob.
No, I agree. Mom, it looks like you had another question, though.
Yeah, no, it's okay. You can feel free. This is like a freestyle conversation.
I'm trying to remember your original question.
My question was like, was there like any disagreements on how basically what type of IMG should be placed or not, or what type, because like there's a lot of discussions around the country that, hey, like maybe somebody like who hasn't gone through a formal program, or somebody who's from this country should not be able to practice. So so that's basically the question I had. Were there any pushbacks?
We didn't hear that when we were working on the legislation. And again, I still don't think we hear that kind of specific pushback. Once the legislation was passed, and as the law is being implemented, we're hearing more questions from folks. Not so much, we don't think we should have someone from this country or that country, but we hear sort of, we worry about things like look-alike requirements. I don't know if you know what I mean, but, you don't have to do a residency, but we want you to take this exam, do this training, and then we'll think about having you, as a licensee. Because people think in terms of residency, even if they're not calling it that. Some people will say, maybe we should add these requirements. But the good thing is the law stands as it is. You can't add a residency program. But I think, and it's mostly not, it's not out of malice or lack of trust of these folks. I think a lot of people just have trouble breaking out of the mindset of, if you don't do a residency here, you're not a physician. And that's partly what the law is aimed at doing, is educating everyone else.
Yeah. Awesome. So you guys got this through, and basically that came out. And then the next step after that was for the Board of Medicine to write the rules. Is that right, Amy?
Yeah. So it turns out in Massachusetts, rulemaking or regulations is not required if it's not explicitly set forth or mandated in the statute, which it is not. So what the board elected to do instead was to issue policies that would not require, that are obviously it's less formal. They issue a policy which can be changed. And the idea there is policy is more flexible. Once you issue regulation, it's really hard to change it. And what the board is interested in is in allowing enough flexibility for the policies to adapt and change in response to the experiences of employer facilities, the insurers, and the physicians themselves. So they issued, I guess what they're initiating, like their initial policy. They're calling it their initial policy on November 20th. And it's up on the Board of Registration of Medicine website. And they are, that policy applies specifically to participating facilities, which facilities should be eligible and how they need to become eligible. And part of that is that they set up a curriculum for the program under the limited license. So that has to be in place first. And it also sets forth some guidelines for that program. Yeah. And they're already, they're expecting to get feedback. And we also have, we're also working with an implementation team that we created, that we convened, which includes many of the stakeholders that were on the commission. And we're working with that team to also both to do outreach to the community health centers and other networks that these team members have for their comments, for their review and comments. And then we're going and actually, so we're going to help facilitate input to the board as well.
Yeah. Another point of disagreement I see around the country is, let's say, we had here in Washington, like we have a program where somebody can get licensed for like, now it's like 8 years. So eventually, but I think it's going to be a pathway to full licensure. We're going to see if there's going to be any assessment or anything, attached to it. But like it was proposed that only hospitals and community health centers could employ IMGs, and like I was heavily against that, because I think like you kind of like shrink the market really low for IMGs, because like in hospitals you have medical students, you have physicians, you have nurse practitioners, you have like PA students, you have PAs. There's just so many practitioners out there that are competing for some patients to work with, right? And like eventually you have a lot of IMGs who won't get the opportunity to learn or maybe practice or whatever. So eventually, like we opened it up. I think so. The rule here in Washington State, and I see in some other states, is like where there are like 3 or more physicians, like a practice group. So what's the rule in Massachusetts? Who can hire an IMG right now?
So the rule is in the law. It says the bottom line is that the Department of Public Health and the Board of Registration in Medicine get to decide. But
Okay.
Well, it's more specific than that. It specifically names federally qualified healthcare centers, community health centers, or a hospital approved by the board. So it's not a smaller practice group, and that was deliberate. And I think, Rob, you're probably the best person to say why we made that choice. And remember, this is just until there's a process, right? This is just for the preliminary phase, right?
Yeah.
So it's that first year or 2 if they renew it. Go ahead, Rob.
I think it comes out of the same ethos as you were talking about, Mohammed, except the reasoning is different. We felt, I think, in the state that the ITPs, internationally trained physicians who were in the licensure program, would not be as well supported in a small practice of 3 people. They're really not going to have the resources and probably the time to mentor them, to help them go through a curriculum and really learn how to practice appropriately in the state. So it was not designed to protect anyone except really the ITPs and their education. Also, we didn't think that smaller practices would be able to meet the requirements of the state in terms of, do you have educational experience? Do you have support experience mentoring people? You could have 3 physicians who have never done any teaching saying, sure, we'd like to have one of these ITPs in our group and we can employ them and it will be less expensive. We didn't want that. We didn't want people being abused in terms of their training.
Yeah. And do you think, and I think that's an amazing point, and you're bringing up an amazing point. But do you think, and speaking to implementation, Amy, do you think there's going to be like enough? Because my question is, like, are you creating because the whole point of residency was like, hey, there's not enough spots, right, for everybody to train in. So by this model, is it like kind of, are you afraid that it might come back to that where like community health centers and hospitals, especially with the question of board certification that I want to get into next, where like a lot of hospital bylaws and hospital privileges won't even have anybody without board certification. Do you think that might cause less placements or less opportunities for IMGs?
I can answer
what
that
I've
one.
heard from. Sorry, go ahead.
I don't think it will cause there to be less opportunities, in part because the issues you raise happen in any practice. And because they're not just practice-based, payers have the same requirements. So if you need to be board certified, it's also the payer who's requiring that, and not just the institution. Many institutions in the state implemented the requirement or do maintain the requirement for board certification, board eligibility, because if they don't have it, the payers won't panel folks. And so the institution won't be reimbursed. So I don't think we're limiting it. We have more than 50 community health centers in the state.
Nice.
A number of neighborhood health centers, which beyond that, a lot of our hospitals, including the safety nets, have offsite practices. So, it depends on what their appetite is for bringing these folks on, which we think will be significant, but we think there potentially could be hundreds of spots.
Yeah. And like once you spoke, Rob, with the community health centers and the hospitals, are they like open to kind of revising their bylaws and including IMGs?
And that's the work we're doing in terms of working on implementation now, is trying to meet with each one of them and ask about this. Most of them are interested in adjusting their bylaws if they need to, or they may have something that allows an opt-out. We are allowed to give an exemption in this case. That's for the institutions. The harder part is getting to the payers.
Again, and the payers, like, I agree. Like, because I've tested it out right in Washington. So the payers, like, from what we've learned, like from Medicare and Medicaid, like you won't have a problem because Medicare, reimburses 100%, and Medicaid, state Medicaid, the same as well. Private insurance is where like everybody kind of draws a line, and that's like where like basically, and that's what hospitals care about. Like that's like a majority of their patient panels, right, in community health centers.
No, you're saying the majority are private payers?
Like at least a significant portion of their revenue, right, is private payers.
Not at community health centers. Most of it
Okay.
is state Medicaid and then some Medicare.
Yeah.
But I would say here, what we've experienced is it actually doesn't make a difference between state payers. So Medicaid programs, and we have a number of different programs in our state Medicaid system, versus private payers. They all actually have very similar requirements because
Mm.
it's kind of a Russian doll. When you get to the innermost part, it's always someone outside the state, outside the payer, who's got requirements. So the institutions have to be responsive to the payers, and the payers have to be responsive to NCQA or other organizations that give them that good housekeeping stamp of approval.
Hmm.
And that's where you find the requirements really start about being board certified or
Mm.
having a US residency. So a lot of our efforts now are aimed at getting to that level of discussion,
Yeah.
both with the payers and the institutions in terms of their contracts with NCQA. Remember,
Yeah.
this is not a state or federal agency. It's unelected. They do great work, but it's not transparent. So
Yeah.
no one really knows what goes into their contracts, their requirements. So we're trying to have a discussion with anyone who has a contract with them, but also with NCQA itself to understand they clearly see that at this point, nearly half the states have or will have laws requiring that these folks be allowed to get licensed and practice. So they've
Yeah.
got to accommodate in some way, but we don't know what that will look like yet.
Yeah, exactly. Especially if you have like Rob, if you have a health system that it kind of uses its leverage, so to change those contracts. So I think that's going to be
Mm.
really
I think
important.
I think it's got to be groups across states,
Yeah.
not just within one state. So any healthcare system could certainly do it, but I think it's for organizations that cross state lines, like the National Association of Medicaid Directors or something like that, to
Yeah.
really bring this issue to an NCQA and other organizations that have these kinds of rules. So at least we can have a conversation, because any one state is not going to be able to. I think they can make the case, but if you have a consortium of states who say we all agree that this needs to be changed, it will be
Yeah.
changed.
Awesome. So, Amy, do you want to chime into that or?
Oh, all I was going to say was I wasn't thinking so much at the beginning about the post-licensure
Yeah.
barriers,
Yeah.
which you just talked about. But one of the things I did want to say is that one of the reasons we have such strong support from the Massachusetts League of Community Health Centers, for example, is because the health centers really do need physicians. There is I don't have the stats in front of me, but most of our physicians are not primary care physicians in
Yeah.
Massachusetts, right? And I forget what percentage actually practice in community health centers, but I know that I had learned that there was at least one center where there was an 8-month wait for
Mm.
for a first appointment with a physician, right? So they are desperate for help, and this is one of those things where since the law actually mandates work in a community health center, this is really going to help them. And so I think based on all of this, there's going to be a great interest on the part of the community health centers themselves and a lot of openings. We also learned from the Mass Medical Society a couple of years ago that within a couple of years, e.g. right now, they were expecting 25% of their physicians to retire.
Yeah. Yeah.
Of their physician members, right? And so I don't think there's going to be a problem with demand. I think it's going to relate more to the questions you and Rob just discussed earlier, which is how do we how do we get these people paneled and reimbursed and all of that?
Yeah, yeah. Really, really great question. So right now, where's the policy / license at right now? Is it like when do you think like people can apply to and look for jobs and all that?
The question everyone asks.
Yes.
I would say TBD, only because we don't like to put a date out. Now that there is a policy from the Board of Registration in Medicine, we can see it's going to be possible, but the practice, the law really won't be fully implemented on their side. They won't allow applications for licensure until the institutions that are going to be hiring the ITPs have a curriculum in place for helping to support them. So
Okay.
the board wants to see that first before
Mhm.
they're going to allow the placement of any physician into an institution. And that we're working on. We're working on the curriculum at the same time as we're working on these other issues.
Yeah. So right now, you guys are like pushing the centers and hospitals. Hey, where's the curriculum? Where's the curriculum? Right.
Well, they're kind of looking at us as well. So the board requires each institution to have a curriculum.
Mhm.
And I think many of the institutions sort of looked at each other sort of in a circle and said, we don't want to all do our own curriculum. Why don't we have one curriculum, a standard one that we can adopt? If we want to change it, we can. And who's going to write that curriculum? And they look around, and it's not them because they don't have the time. But we're hoping to do it as a team.
Yeah.
So we would lead it, and then with really, really deep involvement from community health centers, CMOs, hospital CMOs, heads of credentialing, all these folks to really help build it together so that it's useful in all the sites around the state.
Yep. Yep. Very good point. Very good point. Amy, do you want to add anything to it or?
No, I think, yeah, I would just agree with what Rob said.
Yeah.
And I would say, I mean, we're not going to see anything before next summer for sure.
Yeah.
I don't think.
And
I think that's fair to say. It's going to take time to develop this curriculum.
Yeah, and if there's like an IMG out there and listening to this in Massachusetts, what can they do in the meantime to kind of like support these efforts or work with the MIRA or participate basically?
So one of the things is to meet the requirements, they're going to need to have their ECFMG certification. They're going to need to have passed step 1 and step 2 of the licensing exams, but a lot of them already have that. Some of them have all 3.
Yeah.
But I think the most critical thing is it's definitely going to the pathway is definitely going to favor people who already have institutional connections with these facilities, right? And we know that many of these community health centers and others, federally qualified health centers, already have internationally trained physicians working there in other capacities. So I think the more that people can develop those relationships, the better. I don't know what you would recommend, Rob.
Well, I think it's the same thing that I and others have always advised physicians who are looking eventually to get back to practice is stay involved in healthcare, however it is. Many people work as medical assistants. Some people work as CNAs. Others work as research assistants. But stay involved in healthcare, partly so that your colleagues can advocate for you, but so that you're aware of what's going on in healthcare. And I think that, in conjunction with, as Amy said, meeting all the requirements, is going to put you in the best position to get a license.
Yeah, yeah,
and of course, not be. You would have to be in one of the shortage specialties, which the law specifically mentions primary care and psychiatry, right? Because those are the big shortage areas. So it's not going to be available for people who are in a completely unrelated specialty.
Yeah, yeah. And on the flip side, if there's an advocate, out there trying to do the same thing that you guys are doing in their state, what advice would you guys give out?
Work with stakeholders early on, really early on. We've had great luck, or more than luck, great history of working with the Board of Registration in Medicine. They've been very open to talk to us at all levels, legislator. So you've got to make sure they're all talking to each other too. I know in some states, the legislature and the board may not be seeing eye to eye. So bring them together early on. I think that was the advantage for us of the commission. We had everyone in the same room. It was a virtual room. We had everyone in the same room from the very beginning. So they had to be listening to each other. So whatever
and the
way you can do
major the major physician association, right? The professional associations, like we had the Mass Medical Society having their support, and the Massachusetts League of Community Health Centers too. That was what moved legislators. It wasn't us. Having their their green light and their support was really critical. So it's really also about figuring out or knowing who the big healthcare leader players are in your state. And I completely agree with Rob, like getting them on board early. This is what we did through a commission. Obviously, it's not the only way to do it, but you do have to have them all in conversation with each other, because then what we were able to do was say to the legislature, this bill is recommended by this governor's commission, with these players in it. And that really helped a lot, to be able to say that. I'm trying to think of other things that were really important. I mean, I guess, we're aware that our model is different from other states. Mm-hmm. And I think we really believe in our model because one of the things that's, by not requiring formal supervision, by not requiring that in our law, what ends up happening is the law is really able to increase capacity at the participating facilities. It doesn't cost them much. If it costs, it's not like,
that's
right?
a really
Isn't
important point. It's
they can bill for that person's care. They can bill for it. In other words, they're not just having to bill under a supervisor, which doesn't increase their capacity at all. And I think that's unusual. We may even be the only state that does it. I don't know. I think there might be one or two others, but I would say to really think carefully about when they're putting the law together, about what they're doing, because otherwise what happens is, we've heard, that there are, employers don't want to hire people because it's going to cost them money.
Mm-hmm. That's true.
So it's cost neutral both at the state level and at the institutional level.
Yep. All right. Thank you guys so much for joining me today. Amy Grunder, right? Is that it?
Yeah, that's it.
All right. So Amy Grunder, Director of State Government Affairs, and Dr. Robert Marlin, Special Advisor for Healthcare Workforce. Thanks again for joining me. Really appreciate the conversation, and I think a lot of people are going to learn from what you guys are doing here, and and time will tell. Like, everybody's competing to be the best policy out there, so let's see.
Thank you, Mohammed.
All right,
let's do it again in about a year and a half.
Yep, yes. Let's do it again. I definitely want to have you guys on.